सर गुड मॉर्निंग, कैसे हैं?
बढ़िया
Good
बढ़िया
morning.
now live.
अरे
We are live now.
Good morning.
बस
Good morning.
अरे
On
सर
behalf
बस
of IP
क्या
Delhi,
आईआईपी दिल्ली तो ठीक है सर, ये तो पूरी आईआईपी घूम रही है उधर, कहाँ पे है सर?
sir, good morning. On behalf of IP Delhi, I welcome you to the first session of Master E classes in rheumatology. We have esteemed faculty from all over country, and also Vice President Eastern Zone, Dr. Prashant Subodh, who is joining as chairperson today, and Dr. Khurshid Ahmed Wani, EB member from Jammu and Kashmir, joining as chairperson. And I request our President IP Delhi, Dr. Pankaj Garg, to say a few words.
Good morning, everybody. So Delhi IAP always stands for academics, and in this year 2025, we have lined up our e-master class in various topics. We are starting with pediatric rheumatology. There are going to be 12 sessions on every Sunday, 9 to 10 or 10:30, depending on the length of the lecture. And this will last for 12 weeks. Followed by that, be ready that we are going to launch pediatric cardiology masterclass. Then we have neonatology coming up again, and then endocrinology. So that is the plan for the whole year. So we want to keep you engaged so that your academics improve, and the programs have been made in such a way that they are for office-based pediatricians. So we are trying to cover topics so that we don't miss this diagnosis in our day-to-day practice, and that is why all the speakers have been requested to give a ample time for question answer session. So we are trying to say that the session should last for around 40 minutes, and then 20 minutes and onwards, as our experience has been with previous e-master classes, the discussion goes on for a very long time, and that is the best way of presenting it in length. So I welcome you all. I welcome our chairperson, Dr. Khurshid Ahmed Wani, the EB member from Jammu and Kashmir. And I welcome Prashant Sabodh sir, our East Zone VP. So we are very happy that we are joined by all the stalwarts and the faculties as excellent. So thank you so much, and keep learning, keep enjoying the academic program of Delhi IIP on every Sunday morning. Over to you, Dr. Ajay.
Thank you, Dr. Pankaj. I request our secretary, Dr. Shamina, to say a few words.
Thank you, sir. Very warm welcome to our East Zone President, Prashant sir. Also, Vasav sir also looking in the screen, and our EB member from the J&K, Vani sir, or all, especially our speaker, or Dr. Sujata ma'am, and all respected dignitaries. And thanks to especially Ajay sir to organize this very important topic for the all participant. That definitely that is a work for the all student as well as clinician. That is very important things in the rheumatology, pediatric rheumatology aspect of the pediatrician. Over to you, sir. Kindly start.
Thank you, Dr. Shyam. We are fortunate to be joined by Dr. Baswara sir, past president of IIP, Central IIP. We request him to say a few words of blessings.
Thank you very much, Dr. Ajay Gupta ji. Ajay Gupta ji is our gem of IAP, who has been doing a wonderful work under the guidance of our Delhi president, Dr. Pankaj Garg, and the dynamic secretary, Sham Meena ji, and our executive board member, Dr. Mukesh Dankar, Mukesh Verma ji, and all others who has been doing a great academic work. Best wishes for the very specialty, emerging specialty program of rheumatology, which is one of the most upcoming specialty, which where the pediatrician needs to be aware about it. Best wishes. Thank you, Ajay. Thank you very much.
Thank you so much, sir.
Thank you, sir. We have Dr. Anu Maheshwari, Professor of Pediatrics at Kalavati Children's Hospital and Lady Harding Medical College, who is the program coordinator for this program. I request her to say a few words.
Good morning, sir, and respected members of the IAP who have given me this opportunity to make this program. And I'm very thankful to my colleagues, Dr. Avinash, Dr. Patra sir, Dr. Narendra Bagri, Dr. Neha, Dr. Sujata ma'am, who is the first, I think, the first pediatric rheumatologist of India, in fact. We're very thankful to her that she's agreed to take a talk today for us, and we are hoping, sir, through this that we stop missing pediatric rheumat diagnosis. Like in Kalavati, It's a gold mine of clinical work. And we have realized that even in critical care, or you see any specialty, neurology, renal, cardiac, I think a lot of it is pediatric rheumatology diagnosis that are being missed. We are hoping that by the time we are wrapped up with our 12 sessions, we would be a little wiser, but I think we should keep doing it. And thank you, Ajay sir, for giving me this opportunity to, kind of formulate this course with sir's help, of course. Thank you very much, sir.
Thank you, Dr. Ani. Anus, ma'am, I request our past president, Dr. Alok Bhandari, sir, to please say a few words.
Well, good morning, friends. It's a great pleasure to have to be on the platform for the launch of this important session on e-rheumatological classes. Basically, as I welcome our dear friend Prashant Sabot sir, National Vice President from East Zone. Sir, as you know, Delhi, out of all professional bodies, IAP is the forefront leader with more than 48,000 members, biggest professional body in India. And at the same time, it is also that we claim to be the academic capital of India. Delhi has got more than 38 academic institutions where we are imparting postgraduate classes, and IAP Delhi is in the forefront. And this is our another initiative to tap the untapped wali baat hai ki we are always in the academics also at the forefront. And I also welcome our North Zone Kashmir EB member current Dr. Khurshid Wani sir. Please welcome sir. Khurshid Wani ji. And it's a great moment for Delhi IAP. Thank you, please, and happy learning.
Thank you, sir. Today's session will be taken by Ma'am Dr. Sujata Sawhney, ma'am. She is Senior Consultant at Sir Gangaram Hospital. It will be coordinated by Dr. Dolly Madan, Professor of Pediatrics at Kalauti Children's Hospital. We have Dr. Prashant Sabot, Vice President East Zone. I request him to please say a few words.
Yeah, thank you, Dr. Ajay. Thank you for giving this opportunity to. This is a unique thing that I got. This I really feel fortunate that Sujata Madam's session is there and I am the chairperson. So I feel really proud and privileged. In Eastern Zone, entire Eastern Zone, I will say, pediatric rheumatology is still, it is something which is untouched. In the entire state of Odisha, we have only two pediatricians who have done fellowship in, pediatric rheumatology. But honestly, we have organized one national rheumatology conference in Bhubaneswar in the month of July. So there, the youngsters, they participated in a huge number. And it was an eye-opener that we are now trying not to miss any cases. And we are referring to them, and there's a video call, there, discussions. And even Kawasaki, during our PG time, it was understood that it is only a disease of Japan and of Korea and other countries. So now we get so many Kawasaki diseases, and we are able to, diagnose it early, treat it early. It is really doing a miracle. So rheumatology still in India, I feel that there is a lot of work to be done. Thanks to IAP Delhi chapter, Ajay Gupta sir, and all other the East team members, that they have taken this initiative. And I feel this recording should also be shared and somewhere kept so that it will benefit the, our youngsters and PGs and others. So thank you.
We'll share it with you.
It will be shared.
Yeah. Without wasting time, let's start the session.
Dr. Khurshid Ahmed Wani, few words, sir.
Good morning, dignitaries. At the outset, I thank IAP Delhi President Sir, General Secretary Sir, Dr. Ajay, dear Dr. Ajay Sir, for giving me this privilege. I really congratulate the team for their hard work organizing such wonderful educative programs and nationwide dissemination of knowledge. The timing and the days also very convenient for all. The faculty is really outstanding. The selection of topics is really appreciable, common, useful for general pediatricians, and who get very less exposure during their training period. Previously, the hematology sessions were really very informative and updated. I know the present series will be highly helpful in daily clinical practice, and I wish the success for the program. Thank you.
Thank you so much, sir. Thank you.
Thank you, Dr. Vani. Now I request Dr. Sujata Sawhney ma'am, please start the presentation. I request everyone to keep your mic on mute and post the questions in question answer box.
Okay, so thank you so much. Ajay, I have a request. Please don't share any of my slides because there are a lot of patient IDs which have not been covered. I would need to camouflage that before I can give any permission for public sharing. Thank you. So today I'll be talking about a simple approach to rheumatological disorders for the office pediatrician. And from a pediatric standpoint, when should you think about patients that may belong to this specialty? Well, as pediatric rheumatologists, we see a spectrum of disorders. Arthritis obviously is the first thing that would come to your mind. In addition to that, we see several connective tissue disorders, the prototype of which is lupus. We see many vasculitides, both primary and secondary. And commonly in pediatrics, we see Kawasaki and Hinoch-Chonline purpura. Autoinflammatory syndromes are being increasingly recognized. I will touch upon these, but not tell you a lot about this in detail because you have a session on this later on during the year. We also look after many patients who come to us with musculoskeletal manifestations in the context of having an underlying systemic disease. So, for example, we can have patients who have a common variable immunodeficiency and can present with arthritis. We can have a child with mucopolysaccharidosis who can come to us with joint contractures. And we see a huge number of children with pyrexia of unknown origin. Keep in mind that the longer the child has fever, the less the chance of it being an infective etiology. So pediatric rheumatology really is a branch that can identify diseases that belong to different specialities because many of these patients present with predominant musculoskeletal manifestations. So we are really musculoskeletal specialists. So it is said that pediatric rheumatology is the last bastion for the clinician. And shortcut in this area always leads to trouble. So, for example, you willy-nilly order for a child who's overweight, not doing any exercise, who's indoors, who's run down, who's got exam stress, and the child is complaining of pain all over his body. You run an ANA and the ANA comes positive, and then you start going down the rabbit hole. So for every patient, you have to take a careful history, including being a pediatrician, the growth, the milestones, any issues after vaccination, what are the complaints of this patient, what is the family history, because there are many reasons for joint pains, and a lot of this elucidation will come from a detailed history. So rheumatologists then, to summarize, a pattern recognizer. So what are the tools that we have in our hand? We are very simple people. 85% of the diagnosis comes from the history, 10% from clinical examination, and only 5% from labs. So you need to have a wide knowledge base about the clinical presentation, which investigation, interpret the investigation, and then come to a particular diagnosis. So in pediatric rheumatology, history gives you 85% of the information, clinical exam adds 10%, and 5% are the labs. A very big issue that you would face is how do I find out whether this joint is swollen or not? And that is something you have to learn via attending workshops and by looking at some YouTube tools such as the pediatric gait, arm, legs screening, spine screening, which is a very basic tool that can help you to direct more careful clinical examination. So a pediatric rheumatology patient can come with issues right from head to toe. You can have alopecia as part and parcel of connective tissue diseases, and you can have your toes with blackening and gangrene because of a systemic vasculitis. So every system can be involved in this specialty. Some important pointers for you. So a rheumatological complaint may be a non-rheumatological disease. For example, you can have an acutely swollen joint because of a child with hemophilia, but that's not a rheumatological cause, that's a hematological cause. There's no such thing as a rheumatology panel you have to ask for. You have to look at the differential diagnosis and only then ask for few directed investigations. When you take support from the laboratory, be careful. You should know the method that the test should be done for. And when you are ordering a test, you should know the pre-test probability of the test that you order. So for example, today If in case you want to diagnose a child with lupus, the entry criteria for that patient is a positive ANA on an indirect immunofluorescence. So the pre-test probability of an ANA being positive in a patient of lupus is in excess of 98%. So it's a smart screening tool. And the contrary example I can give you is that a rheumatoid factor is present only in 5% of children with juvenile arthritis. So what does that mean? The pre-test probability of the rheumatoid factor being positive in a patient of juvenile arthritis is only 5%. So it's a very poor screening test. So you have to know the technical details about the test that you order. And this, I think, is one of the most important statements. No test can rule in or rule out any rheumatological disorder. The diagnosis has to be clinical. So every patient requires a systematic approach. I will not talk about in detail about any particular disease. I'll in fact talk to you about the clinical manifestations that children may come to your clinic with. So today we will discuss 5 important clinical manifestations. How do you approach children with joint pains, prolonged fever, a suspected connective tissue disease, a vasculitis, or some miscellaneous causes? We'll try and keep this discussion case-based, and then I'll try and leave you with some take-home messages. So let's start quickly with joint pains. So case, 12-year-old, febrile for 4 weeks, moderate grade fever, severe pain and difficulty in the knee, followed by the wrist, the elbow, and the shoulder. So a migratory pattern. On clinical exam, you find the child has mild pallor, but nothing else. And these are the reports that this patient presents to you with. Please note the difference between the white cell count going high and the platelet being low normal. So this is a very unusual constellation in pediatric rheumatology. You have a friendly adult cardiologist and the echo is reported as a trivial mitral regurgitation. And of course, the laboratory gives you an ASO titer, which is positive. So the child is diagnosed to have acute traumatic fever. The major criteria fulfilled is the echo positive MR, and the minor criteria as listed. This patient is started with aspirin and Panadol. But this child doesn't improve. She has very severe back pain. You examine her, you find sternal tenderness, and you do a bone marrow, and the child turns out to have acute lymphoblastic leukemia. So please note, migratory joint pains are not always acute rheumatic fever. There were several mistakes here, and I have this little graph down here for you. If you say the upper line is the ESR, the second, the white cell count, and the third, the platelet count, in inflammatory disorders, they march in the same direction. When you have a platelet count which is low and a white cell count which is high, this is a red flag. The only exception to this rule is SLE, but in those children, both the white cell count and the platelet count will go down. Remember, if the platelet count is discordant to the white cell count, you have to be very, very careful and think of an underlying malignancy. So you should not be over-reliant on laboratory test, and nowhere does it state that an ASO elevation alone, without fulfilling any major or minor criteria, you can diagnose rheumatic fever. So if a patient is exposed to the streptococcal bug, the ASO titer goes up in more than 95% of patients, but the sequelae of acute traumatic fever are seen only in 3 to 5%. So that, excuse me, so that if in case this patient does not have the classic clinical features of rheumatic fever, just an ASO elevation does not mean acute rheumatic fever. It has to be in the context of the clinical features. And it was way back in 1963 that Sievers published a paper to state that ASO is elevated in 1/3 of patients with systemic arthritis. So ASO titer is a huge bugbear, and you have to be careful when you give it any clinical consideration. So what are the clinical features of children with acute traumatic fever? The polyarthritis will disappear within the first 6 to 8 weeks' time. Persistent fixed arthritis does not occur in rheumatic fever. You have to be careful about that, recognize the pattern. So I think that this case tells us that malignancies can present with arthritis. Excuse me, I'm going to come back in just 1 second. Sorry about that. Okay, so when you look at data that is on that has been presented on malignancies, we can look at it from two ways. One is we can look at it from a rheumatic standpoint, where musculoskeletal complaint patient were found to have a neoplasia. The commonest manifestation here was acute monoarthritis, and note that all patients had normal counts. What is suggestive then? What is suggestive then of acute leukemia is disproportionate pain, the presence of periarticular disease, a high LDH or an X-ray abnormality, and note that the MR imaging of the involved area can often be normal. So some pointers towards malignancies in your population. The patient can have acute monoarthritis. The arthritis can be of a migratory pattern. The pain is very severe. The child can have type B symptoms. The LDH can be very high and the MRI can be normal. This was a very elegant study that was recently published from an Italian cohort. Patients with malignancies, more than 1,200, were reviewed for MSK features. 1 in 4 of these children with malignancies from nationwide oncology centers had MSK features. 64% of these patients in the MSK features had joint complaints, of which about 1 in 2 children had a monoarticular pain. In a multivariate analysis, the male sex, monoarticular disease, severe associated limb pain, and thrombocytopenia were at the highest risk of having an underlying malignancy. So you have to be very careful about malignancies in children who come with severe joint or limb pains. And the worst thing you can do is to use an NSAID or a steroid early on without having a correct diagnosis, because all the clinical features would be masked. So broadly, when you have children who come to you with joint pain, you want to distinguish whether the child has an articular inflammation, a periarticular inflammation, or in fact has no inflammation. When a child has an inflammatory joint disease, the prototype of which is childhood arthritis, these children in the history will tell you that they have early morning stiffness, they get better with movement, the clinical course is fluctuant, and they may have an associated joint swelling. Contrast this with children who are hypermobile and present with aches and pains, which is something that a pediatrician will see very commonly. And the ratio would be something out of 95 to 5. So 95% of children who come to your clinic will come with non-inflammatory aches and pains. And these patients often have hypermobility, or they may have growing pains. And these children have pains towards the evening hours, after hectic activity. There is no associated joint swelling. These children get better with rest and worse with immobility. So please note the differences between inflammatory and non-inflammatory joint pains. The other issue is when a child has got periarticular inflammation. Now on your slide, you will see that the ankle of the right side is swollen as compared to the left side. And this patient has in fact got a swelling behind the lateral malleolus on the right, where the lateral malleolus on the left seems to be normal. So these patients can have what we call tenosynovitis. And if the tendoachilles is swollen, these patients are said to have enthesitis. So in addition to the inflammatory causes of periarthritis, please note that children who have neoplastic disorders can also have periarthritis. So you have to evaluate these children very carefully. Today we have a tool called the ultrasound. So you are aware that POCUS, point of care ultrasound, is becoming a big flash word in the world of medicine. And we use it in our clinic for the last 8-9 years. And here you can see the tendons which are surrounded by a sheath of fluid. And this is the ultrasound examination that is confirming the presence of tenosynovitis. So there are many reasons for then children to present with articular inflammation. Please understand that whether it is a bacteria, it is blood, it is a distant infection that is reactive arthritis, or it is an autoimmune disease. There are so many triggers for the joint to be swollen, and a swollen joint will look very similar for many, many conditions. Perhaps a couple of exceptions are when the joint is red, hot, and swollen, which is a hallmark of septic arthritis, acute reactive arthritis, or infrequently hemarthrosis. In all other conditions, the joints do not manifest the classic dolor, calor, rubor. They are warm and swollen, but not red hot. So red hot is very few differentials. So look at this picture on your slide and notice that the right knee is swollen, but the swelling is extending beyond the joint line here. And then when you look at the associated X-ray, you find a lytic lesion in the tibia, and the MR shows you the pus collection even in the soft tissue. And this child is a case of tuberculosis of the tibia with that juxta-lesional sympathetic effusion of the knee joint. So your clinical examination has to be tip-top. When you come to causes of chronic arthritis, there are many and they are listed here, but note that any of them can present to you acutely. So you can have an acute manifestation of a usual chronic disorder as well. And like I said, there are many differentials. How do you approach these children? You have to recognize the pattern for each particular disease. So if a child has arthritis, confirm it with a clinical exam. Is it a monoarticular disease or polyarticular? And then in each subcategory, is it acute or chronic? Is it just the joint or is it associated with something else? And if in case you find that it's something else, you have to be very careful about mimics, and that will come through the slides. So the history then is very important in children with joint pains. And once you are confirming that the child has an arthritis through the history and exam, you then have to tease out, is it a connective tissue disease, a vasculitis, an infection, a malignancy, or indeed does this child have a mimic? So here's a clinical picture of a 14-year-old child with polyarthritis. And here's the picture of an 8-year-old boy who has symmetric deformities of only the PIPs. However, this child has a short stature. And can you see on the dorsal vertebrae X-ray, this child has got anterior lipping. So this child has a mimic of juvenile arthritis, and this diagnosis is spondyloepiphyseal dysplasia tarda. So when you have mirror image swellings that don't feel wet on a clinical exam and your child is of short stature, this patient may have a juvenile arthritis mimic. Here's another one who's got more contractures of the joints which are coming from the flexor tendon rather than a joint swelling per se. And the differential diagnoses for these patients are so many. This child turned out to have mucolipidosis. Again, if you're not sure where the swelling is coming from, and a POCUS is very, very helpful. And here's a child who's showing you fluid in the ankle joint and another one who's showing you fluid in the knee. So ultrasound examination is an extension of your clinical examination. And remember that diagnosing children with articular complaints is very important because you want to treat your patient early on. And what you don't want is these large scars in children who present with monoarthritis. And this often happens because of a doubt of a tubercular joint in India when the child presents with a monoarthritis. But remember, the commonest manifestation of oligo-GIA is also monoarticular, and there are some features that will guide you towards the correct diagnosis. Included amongst them is a history of early morning stiffness, negative evaluation for tuberculosis, and sometimes evaluation of the eye that shows you that the child has got a chronic anterior uveitis. Why do you want to make an early diagnosis? Because if you don't treat the joint, the child gets a deformity, and then you have to take this child to the operation theater, take the help of an orthopedic surgeon, and after you inject the joint, you need to straighten out that leg. Very important. Otherwise, the child would walk with a deformed leg, and this deformity will then give rise to an early osteoarthritic degenerative change in the joint. Oligoarticular children have relatively painless joints. Severe pain does not occur, but every contracted joint is not juvenile arthritis. And here's a girl who presents to you with a gradual onset contracture of the right knee joint, but the history is not inflammatory. And this patient had a discoid lateral meniscus. Here's a boy who's got a swollen right knee joint. This is a chronic hemophiliac joint, as is this one. Psoriatic arthritis is seldom seen in India because the patients tend to have psoriasis for a very long time before they develop the disease. But remember, these children often have dactylitis, which is swelling of the whole toe rather than swelling of a particular joint. So that's very important. When you come to the systemic form of arthritis, remember that there are many causes for fever and arthritis. Systemic arthritis is only one of those causes. The ILR has given us several features of systemic arthritis, but note one of the most important clues is the fever type, which is cutodian, whether fever goes down below baseline when the child is well, and whether the child is very well when the child does not have fever. Additionally, if in case you get this classic evanescent salmon pink rash, then there is really no differential diagnosis. The subcategory of spondyloarthritis or enthesitis related arthritis is more common in boys than in girls, but here you have twin sisters with the same condition. Unlike the child with oligoarthritis, where the eye is quiet but can blind, these children, if they develop the uveal inflammation, have an acute, painful red eye. And this patient is demonstrating to you what is called a hypopion within of the anterior chamber. So, recognizing the reason for joint pain is all about pattern recognition, where several features are taken into consideration, and that in itself is a separate masterclass as to how you need to decide the pattern for the patient and pick up the correct diagnosis. Tuberculosis is a huge worry for us being pediatric rheumatologists, and the commonest presentation there is a monoarthritis, but by no means is every monoarthritis tuberculosis. Requires careful evaluation. In a tubercular dactylitis, which is very different to a psoriatic dactylitis, you can see that a plain X-ray helps you out, and this patient is showing you osteomyelitis of this particular bone. In addition, you have a Brody's abscess as well in the tibia. So let's now change tack from joint pains and move to a febrile patient and what can be the differential diagnosis of pediatric rheumatology. There are many differential diagnoses of PUO. Rheumatology is one of them. About 20 to 25% of patients have a rheumatological cause for a prolonged pyrexia. There's also a condition called CEFUO, that is chronic episodic fever, and some of these children can have an underlying autoinflammatory condition. When you look at the subcategories of prolonged pyrexia, the child with a rheumatic disorder is dominated very often by arthralgia and myalgia. A child who has a neoplastic FUO is often dominated by fatigue, weight loss with an early and dramatic decrease in the appetite. And an infectious fever is often accompanied by chills, night sweats, and weight loss, albeit without a significant loss of appetite. Of course, some of these features can be overlying, but this is a broad differential diagnosis. So when you have children where you suspect a rheumatological cause, what can these causes be? Amongst the arthritis, you can have systemic arthritis, enthesitis related, 7% have fever, or a child with an explosive onset reactive arthritis can present with fever. In the vasculitis, you are well aware that Kawasaki and Takayasu osteoarthritis can both present early on with only prolonged fever. Very rare in your practice as a general pediatrician. 1 in a million children can have ANCA-associated vasculitis, but these patients can have a devastating clinical presentation. We'll discuss that. And then here you have listed the other causes of prolonged pyrexia. The initial workup has to be very broad for every child. And today, imaging, either MR or CT of the chest and abdomen, must be done before you label a child to have a pyrexia of unknown origin. The ESR can guide you, but not always. The ESR is often high in pediatric rheumatological conditions, but occasionally may not be very high. So how do you pick up these patients? Again, you have to find out the pattern for these patients, and the symptoms that you have to be carefully look for should include the fever pattern, the features of connective tissue disease, and also the features of systemic vasculitis. Often it is the extra-articular features that will lead you to the diagnosis. That is to say, in a child with prolonged pyrexia, if you find that the child has got oral ulcers, you may want to think of Behçet's or lupus, for example. In a patient who's got prolonged pyrexia and has got a malar rash, you may want to think of lupus. If the patient has got skin vasculitis and hypertension, you may want to think of systemic vasculitis, and so on and so forth. So features other than joint involvement often give you the clue for the underlying investigations. Repetitive as may sound, the history, the clinical exam, and few investigations will lead you to the correct diagnosis. There is no such thing as a rheumatology panel of investigation because that only causes more confusion. The age of the patient can help to guide you as to the rheumatological cause for the prolonged fever, such that in infants under 1, you want to think of infection, primary immunodeficiencies and autoinflammatory conditions. In older children, you want to think of Kawasaki and systemic arthritis. In a child between 5 and 10, you would like to consider systemic and reactive arthritis, in addition to perhaps some children with lupus. And it's the older children where you're more concerned about systemic vasculitides. The exception here, of course, is Hinox-Schönlein purpura and Kawasaki, which occur in the younger child. So let's move on to another case. So here's a 17-year-old, and this patient was referred to us more than a decade ago by another hematology team from another hospital. And this patient had a long checkered history. She had low-grade fever. She was then diagnosed to have pulmonary cox. She was then thought to have CNS tuberculosis. By the time she came to us, she'd had a couple of courses of ATT. And her evaluation showed bilateral pleural effusion. She had low platelets. The bone marrow done was reactive and the ANA was low titer positive. So this patient was then thought to have maybe lupus. Excuse me, and from another hospital. She'd already been started on oral steroids. She presented to us, in fact, in the emergency with severe pain in the abdomen and persistent fever. So this patient has a long course, which is multi-system in nature, and the ANA is positive. Does this patient have lupus? In fact, this patient turned out to have HIV. So remember that infections are a very big mimic of rheumatic diseases. And it's good practice that when you're hunting around for causes of thrombocytopenia, please don't forget running an HIV and also looking at the immunoglobulin profile of these patients. Children with systemic arthritis have a classic fever pattern, and here you can see the child presenting with arthritis, rashes, and fever. However, early on in these patients, you can have children who present to you with macrophage activation syndrome, and that's a very, very big issue. Differentiating systemic arthritis from other febrile conditions can be very challenging because more than 70% of children may not have arthritis at presentation. There's a lot of work going on for newer biomarkers, and perhaps in the future, the level of interleukin 18 in the blood or looking at a blood report called MRP 814 may be very, very helpful. But currently, we don't have these available in the laboratory. What is very challenging is when the child with systemic arthritis is presenting to you in the clinic with features of macrophage activation. So please remember, it's good clinical practice to run the serum ferritin in a febrile child where you're hunting for the diagnosis, because there are some reports in literature that state that more than 10,000 is highly suggestive, though not pathognomonic, for patients with rheumatological causes as the underlying cause for fever. But note, in our own center, we have seen children with dengue shock syndrome with serum ferritins of more than 100,000. A lot of these reports are written in the West, where they do not see exotic infections that we do. So no test can give you the correct diagnosis, but it can point you in the direction. One error that we tend to see is that pediatricians often wait for these children to fulfill the HLH criteria. Now, please note that's downright dangerous because children with systemic arthritis begin from a very inflamed position with high white cell count and platelet count, such that a relative drop of counts is highly dangerous and suggests systemic arthritis with a complication of macrophage activation, as these reports show you here. There are a lot of reams written on separation of systemic arthritis from macrophage activation syndrome. Excuse me 1 minute. But please note that there are some patients with macrophage activation syndrome who may not fulfill all these criteria. You are aware about the many causes of hemophagocytic lymphohistiocytosis, and rheumatological diseases are merely one cause for secondary HLH. We can skip these slides. So please note the concept of cytokine storm syndrome. Essentially, hemophagocytosis can occur in the presence of sepsis, where the requirement for the patient is antimicrobials, or the patient can have a genetic cause where the requirement for this patient is a bone marrow transplant. So cytokine storm syndrome can occur in many conditions, and rheumatological causes are only one such underlying cause. So it's very important that when you are trying to diagnose the reason for a secondary hemophagocytosis and that cause is occult, you should consult with your hematologist and consider whether that child requires evaluation for a congenital HLH, whether the child has an underlying primary immunodeficiency, or whether the child has got an underlying infection such as a CMV reactivation. So the bottom line then is macrophage activation is a clinical diagnosis. 50% of these patients can have the macrophage activation at disease presentation, and systemic arthritis is only one underlying cause. So remember, don't forget rheumatological causes for clinical emergencies. Connective tissue diseases in the context of a general pediatrician, there are many differential diagnoses. Systemic lupus is the prototype condition. When do you suspect these cases? When you have children with prolonged fever, arthritis, but with something more, either a Raynaud's or a skin issue or some other systemic involvement. That's when you consider that these patients are likely to have a connective tissue disease. Remember that many of these children have vertical disease presentations. I'm going to skip this, and then I'm going to come to you basically, when do you suspect systemic vasculitides? This is suspected when these children can present with a combination of several of these clinical features, such as the presence of purpura and arthritis, the presence of mononeuritis multiplex with sinusitis, the presence of fleeting lung shadows with glomerulonephritis. So rare clinical features coming together in a child under 16 should suggest an underlying diagnosis of systemic vasculitis. All right. I'm just going to skip this. So connective tissue diseases, the commonest prototype is childhood lupus, but remember 50% do not have a malar rash, and there are several clinical features that suggest the diagnosis of lupus as well. Like I said, only half have a malar rash. Systemic vasculitis, you have to look very carefully. Look at the ears, look at the feet, look at the toes. And here's a young boy with Henoch-Schönlein purpura with a very remarkable angioedema of the feet. In our own cohort, we find that when children present with lupus, fever and cytopenias are one of the commonest clinical manifestations. So here's another young child who presents with fever and joint swellings, where the ANA is negative, where the child is thought to have systemic arthritis. But a very big mistake here is the ANA testing on ELISA. So when you ask for a screening test for lupus, it must be ANA on indirect immunofluorescence. So this patient's diagnosis was missed because the test was done by the wrong method, and this child then proceeded on to have a renal involvement, and only when she was hypertensive, had a seizure, came to the ER, was the correct diagnostic label given to this patient. Dr. Ajay, I'll complete in the next 5 minutes. So the ANA screening must be by the proper method on indirect immunofluorescence, where you look for certain detailed patterns that we can miss on. You can have children with juvenile dermatomyositis like this patient who presented with prolonged fever and marked facial edema. So that Anasaka, it is a rare presentation of juvenile dermatomyositis, and most literature would suggest that fever may not be a dominant clinical feature, but it is seen in some children. A prototype of children who present you with puffy hands is mixed connective tissue disease. Here's a child who's got facies of systemic sclerosis and the association with interstitial lung disease. I'm just going to show you some pictures, like a picture atlas for you. Here's a child with patch morphea. Here's another one with linear scleroderma. Here's a child with parotid swelling, and this patient had sarcoidosis. In the context of systemic vasculitis, there's a lot of confusion amongst pediatricians. It should not be the case. The common diseases you see are children with Henoch-Schönlein purpura, and you know the classic clinical trial. Here's a young infant with a variant of Henoch-Schönlein purpura called acute hemorrhagic edema. Why is there a confusion? Because the presentation of vasculitis can be of many types, but let's keep it simple. Large vessel vasculitis in pediatrics is iotoarteritis. The medium vessel vasculitis is either polyarteritis nodosa or Kawasaki, and the small vessel vasculitis can be ANCA associated. And then you have the miscellaneous group of patients who often have only a cutaneous involvement. So we don't have to get confused, but keep in mind that a constellation of these rare features together is likely to suggest the rarer forms of systemic vasculitis. You are very aware about how to pick up Kawasaki and Henoch-Schönlein purpura. Very rarely do you have single organ involvement with vasculitis, and described in the last decade is isolated inflammation of the blood vessels of the CNS. Each patient requires a careful evaluation. So here's on the top left a child with Kawasaki disease, a child with systemic lupus, that is secondary vasculitis, and here's a child with polyarteritis nodosa. So vasculitis can present you in many shapes and forms, and here's a child who had cutaneous vasculitis with nothing else that settled down with a touch of steroids, and we were never able to give a final diagnosis to this patient. So here's another young child who's present to you with iotoarteritis. And remember that this can be a presentation of prolonged pyrexia. And here you see the left subclavian artery on an angiographic study showing you a thinned out vessels, so that this patient's left radial would be likely weaker than the right. So when you say I've examined this patient, it has to be all peripheral pulses as well. Very, very important. And here's another child who's showing you involvement of the infrarenal aorta that is involved. That child did not have good femoral pulses. So clinical exam is very important. Rarely you can have non-healing shadows on a chest x-ray that do not heal. This patient was thought to have a Klebsiella pneumonia, but you can see the CT imaging showing you cavitary lesions. And this child had got Wegener's granulomatosis called GPA. Inflammatory bowel disease may come to you. Sarcoidosis may come to you. Here's a young child with an unusual disease, swollen mandibles, young infant, high fever. And here you have the bone scan with a lot of uptake in the mandible. And this child has got Caffey's disease. Rarely you can have Behçet's disease in your practice with folliculitis and oral apathy. And you can have children coming to you with involvement and swelling of the subcutaneous fat called panniculitis. A very interesting child that I saw in Raipur, and this patient indeed turned out to have leprosy, and you can see the lepra bacteria which are present on the special stains here. So rheumatology can be full of surprises. We have a session on autoinflammatory syndromes, and I will pass on that. That will be done at a later date. But suffice it to say that they can come to in practice. The commonest condition here is PFAPA. Here's a child who's got a rare syndrome with very pustular acne and swollen joints, and again with fever called the Sappho syndrome. Here's a child with fixed rashes, hearing deficit, and prolonged fever. And this child has got an autoinflammatory syndrome. So to close, ladies and gentlemen, familiarity with the clinical presentation of the rheumatic disease is very important. You should recognize the typical pattern, ask for few laboratory tests, think carefully of the mimic. Don't be concerned about giving a very smart immediate clinical diagnosis. Many of these patients require reevaluation time and time again. So thank you for your attention, and I'm so sorry for coughing through this. Thank you.
Thank you, Dr. Sujata Sawhney, ma'am. It was a wonderful session. Please stop sharing your screen. I request chairperson for the day, Dr. Khurshid Ahmed Wani, EB member from for Central IP from Jammu and Kashmir, to have its expert comments.
Sir, very wonderful and detailed in details session by madam. Very informative. Very.
Thank you, sir. Dr. Pankaj, are you there?
I think this is a gist which Dr. Sujata, despite her bad throat, she has been able to put in these 40 minutes. I'm sure a lot of these issues will be discussed again and again in other sessions, and discussion is absolutely important to understand these complex disorders in more simple words. But thank you, Dr. Sujata, for nice presentation.
Dr. Dolly, are there any question answers?
Sir, there were a few questions. I have answered them. One question has come right now. I will answer that, sir. It's a simple question. In fact,
we can ask Dr. Sujata ma'am also.
Yeah. Sujata ma'am, if you're there, there's a participant, Dr. Rajkumar Paul, who's asking that why is ELISA not an appropriate method to detect ANA?
Okay, so thank you for that question. That's a very good question. So the method of indirect immunofluorescence on a Hep2 cell line is the gold standard for testing for ANA as suggested by the American College of Rheumatology. This is because the ELISA plates are manufactured, and the very important thing is that you want to include all the ANA antigens in the ELISA plate for it to be sensitive enough to pick up a positive ANA. When you are doing an ANA on indirect immunofluorescence, the cell line is called the Hep2 cell line. These cells which are used for the immunofluorescence testing are from the human laryngeal cell carcinoma, so that all the antigens within of the nucleus are going to be stained if your patient is carrying the ANA antibody. This may not be the case for ELISA, which is why it is not recommended. It is not recommended as a standard test.
Ajay, you are muted. Ajay, you are muted, please.
Ma'am, Dr. Dinesh has asked, is there anything different in chikungunya arthritis?
So the chikungunya arthritis is a entity which is seen in patients who have the chikungunya viral infection. And as the time goes forward, sometimes these patients can have a symmetric large joint oligo disease, occasionally polyarticular disease in the context of the serology having been positive. Many of these patients settle down with non-steroidals. If they persist for more than 4 to 6 weeks, then these patients can occasionally require hydroxychloroquine to be better. So significant pain along with associated myalgias in the context of a recent chikungunya IgM or PCR positivity is the hallmark for these patients.
Dr. Dolly, are there any more questions? I think one Dr. Naresh Grover has asked.
Good morning, sir. Sir, I'm Dr. Anu. Ma'am, there's another question. Can I tell that?
Sure.
In cases of early RA, what factors can determine the choice of initial therapy, and how do we assess when to escalate treatment if remission not achieved? Actually, ma'am, this is very specific question. Would you like to answer it, ma'am?
Sure. So
Yes, ma'am.
basically, first of all, we will not say that a child has got rheumatoid arthritis. Rheumatoid
Absolutely.
arthritis is an adult diagnosis, and rheumatoid arthritis refers to particular type of symmetric small and large joint arthritis in adult patients. In children, when you have a patient who is rheumatoid factor positive, that constitutes only 5% of children with juvenile arthritis, and these patients tend to have aggressive disease. So today we have got prognostic criteria for the several categories of juvenile arthritis depending upon the disease burden, the prognostic criteria, the imaging, the bloods, the duration of disease of the patient. We will tailor make a therapy for every child such that there can be a child who has got complicated uveitis and is non-weight bearing with one joint where we will start on a biologic upfront. And there can be another patient who has a mild swelling of only one knee joint and nothing else, where we may want to start only with a non-steroidal. So this is a clinical condition with very, very different subcategories of patient, and each child will be given therapy depending upon his or her own disease burden, prognosis, bloods, and imaging.
Thank you so much, ma'am. Ma'am, there's another question. KD is usually thought to present acutely. How does it present with prolonged fever, low grade or high grade? This is Dr. Naresh Grover.
Okay, so when you look at a child with Kawasaki disease, the median time to defervescence is 21 days. Most children who have Kawasaki disease will present with some clinical features of KD that you are well aware of, but the exception is an infant. An infant under 1 year of age and more so under 6 months of age who has prolonged pyrexia for more than 5 days, where the patient is unresponsive to IV antibiotics, you must consider the diagnosis of Kawasaki disease. Even children with giant aneurysms tend to have the fever abating by the end of the 3rd or the 4th week.
Thank you so much, ma'am. Ma'am, there's another question, some very controversial question. Do you feel that COVID infection or the COVID pandemic, has it affected the incidence of arthritis? This is asked by one of the panelists. And the last question is that what is the most common rheumatological diagnosis that are missed by general practitioners that they need to be aware of?
So I don't have any data to state that autoimmune
Absolutely.
conditions and
Yeah.
arthritis have increased after COVID, because I don't think that is my practice. It certainly hasn't gone up
Yes, ma'am.
tenfold at all with any particular disease. One thing I must tell you, that immediately after COVID, in the 6 months after COVID, we had in our hospital a spurt of disseminated
Yes, ma'am.
tuberculosis. And that was
Yes, ma'am.
because of the willy-nilly use of steroids for patients who were diagnosed to have MISC. So I don't
Yes.
think there's been any dramatic increase in autoimmune conditions. What is the commonest condition that is missed by pediatricians from a point of view of rheumatology? Very difficult question.
Very difficult,
Very
ma'am.
difficult question. I think that earlier on, maybe a decade ago, we had many children presenting to us with fixed arthritis and getting injection Panadol 1.2 mega units every
Yep.
3 weeks, but that has reduced considerably. The other thing I must say that we get as missed patients is patients with iotoarthritis, because
Yes.
these children come with prolonged fever. In the inflammatory phase, they do not have any loss of pulses. And unless these patients are imaged very carefully, it's very difficult to pick up the diagnosis. So that these children, you know, the association or the suspected association of tuberculosis and iotoarthritis, many of these kids have a MON2 of 12, 14. The APRs are very high ESR and CRP, and they are given anti-tubercular therapy. So I think in the year 2025, if you are putting a child on ATT, we must hunt high and low. Where is this bacteria hiding? And only then give the ATT for the child. In PUO patients where you're not getting any clue, ESR CRP is very high. Imaging is very important, which is why if you look at any of the guidelines, you don't label a patient to have FUO until you have done imaging.
Absolutely, ma'am. Absolutely. Thank you so much, ma'am. There is another question which I think this is an interesting question. Dr. Krunal Shah is asking, can Kawasaki repeat in 1 year one year 3 times in a child? Uh, I don't think so. I think we'll have a detailed session on Kawasaki and autoinflammatory. Dr. Krunal, maybe we can address it there. And another thing, ma'am, Dr. Gauri is asking, can oral ulcer mimic rheumatic diseases?
Okay.
I think ma'am has, yeah. Right.
Okay, so come to Kawasaki disease. First of all, the recurrence of Kawasaki is under 1%. In my 30 years of doing pediatric rheumatology, I've only seen one child who had a recurrence of Kawasaki. It's extremely rare. And repeated Kawasaki does not happen. So I think the diagnosis may be something different. When you look at oral apathy, there are many, many reasons for oral apathy, and these range from common garden oral aphthous ulcers to inflammatory bowel disease, to Behcet's disease, to herpetic stomatitis, to lupus. So there are so many reasons for oral apathy, and of course it can also be in certain vasculitides as well. So every child requires a very careful history taking and clinical exam to understand what are the oral apathy because of.
That's very correct, ma'am. Actually, one symptom we can't say whether this is rheumatic disease or not. You need to see the spectrum, and I think ma'am has beautifully said that you need to recognize the paradigm. You need to recognize how the symptoms are evolving. And most of the time, ma'am, like you said, 85% says zyada hi. I think 90% of the time, it is like the history that gives us the diagnosis. So don't hold on to one symptom and order the panel. Like there's no panel. I think.
So Anu, you're muted.
Sorry, ma'am. Ma'am, Dr. Vani sir has asked a question that neonatal KD. So I've just typed an answer that neonatal, ma'am, can you share your experience with neonatal KD?
I don't believe I have seen a newborn with Kawasaki disease. The youngest child we've seen is a 3-month-old infant. And like I said, that the younger the infant, the less the constellation of clinical features, the higher the risk of giant coronary artery aneurysms and the worse the prognosis. So you know that today Kawasaki disease is actually not a disease, it's a whole syndrome.
Syndrome,
There are management principles of using upfront intensification in a small group of patients, and neonates are one of them because their outcomes are considered to be very poor, especially from the coronary artery standpoint.
Ma'am, in fact,
Thank you, ma'am.
ma'am, sir, just a minute. Ma'am, Hanji, sir. So, newborn KD, we diagnosed in a few patients, but they all turned out to have some underlying PIDs. So, I think, ma'am, even CGD patients can present at any age with infection and a Kawasaki like constellation of symptoms. So, if it's presenting in an atypical manner, you should look at. I think we'll discuss this. Dr. Patra, sir, has his lecture on KD. I think he'll touch upon this.
Sure.
Thank you, ma'am. I think that's it for the questions.
Thank you, ma'am, so for a wonderful session and the discussion. And if there's still more questions, we can answer them in the group. So thank you very much. Thank you very much.
Thank you.
And
So
thank you to the delegates for-
Ajay, please don't post this. Please don't post this presentation. I need
Sure,
to
ma'am. We'll have
first
a
hide
presentation.
the identities.
Sure, ma'am.
Sorry about
Sure, ma'am.
that. Okay.
Sure. Thank you so much.
Do
Thank you all the delegates and respected faculty. Mr.
Thank you
Sushil,
very
please
much.
close the session. Sir wants to say something.
Sir, it's been a great session and a perfect launch of this e-classes in pediatric rheumatology, and one line message which I'll give to the younger students, the next generation. What Madam Sujata has told is history, history, and history. 85% of the diagnosis lies in history, and which modern day students, what I see is in 1 minute, they just write down 10 investigations for a patient and the patient is sent off. So I will again request, please heed to Dr. Sujata's pearls of wisdom this morning that history taking is very important and it's a very great take-home message. Thank you, Sujata ji. Thank you, Anu.
Thank you so
And
much.
Dr.
Thank you, sir.
Khurshid and Dr.
Thank you, sir.
Prashant. It's
Thank you
been
from
great
IIT
learning.
Delhi.
Thank you, Dr. Khurshid, for joining in
Thank you
and
very
taking
much,
this
sir.
session.
Thank
And